Hello, my dear students. I think this was the most awaited session. You have very recently completed the INICET exam. I know many of you are aspiring for to chase your dreams, but then it is a good time to learn by our own performances in terms of positivity and negativity. Yes, you have. If you have done it, most of it is correct. Then you feel motivated and you will do more corrects in future. If you have not done it, it's a very good time to learn by mistakes and not to repeat the same, and also to get the glimpses of what kind of questions are around, and then to get better prepared for the upcoming exam. So, with that intention, I, Dr. Ranjana S. Ranade, am here to discuss INICET May 2024 Recall Pathology questions, and a very good evening to one and all who are attending this session. So, this I told you what was the trend so far that we discussed when I actually took the recall session of the previous exams a few days ago, right? So, general pathology, this was in percentage, weightage was 37, and look at here the hematology, blood banking, the weightage was 29%. Now, what changed a little bit is you can see that about 28 questions are in pathology, and out of which you can see that 10 plus 6 are, that is about 16 questions are from general pathology and hematology as well as blood banking. The very important thing about blood banking is in this exam, even though the topic is the blood banking topic per se is not, you don't need to read more than 2 hours or so to complete the entire blood banking topic, but then the questions, the intensity of this topic or the importance of this topic is very, very important. So even in this exam, this was reflected. From systemic pathology, we have a good number of questions. Pathology in isolation, as well as it is integrated with the other subjects, right? Now, with respect to clinical and practical pathology, some of them also belong to hematopathology also. So there were total of 3 questions which are actually integrated here. Okay, hematology, blood banking, and clinical pathology. So I'll be discussing those 28 questions and 2 more questions which I think definitely you will help me in completing those questions and what were the exact options. Okay. So, what were the questions based on? Yeah, I will be definitely discussing what were those questions and what were those subtopics. Okay. So, a difficulty level, I think you should be the better ones to tell. If you ask me, for me, it's of course most of the questions, like from 28 up to 25 questions, were very easy to moderate, and one was really, really difficult, right? So, that was the difficulty level, not very tough. So, in general pathology, the questions were from apoptosis and necrosis, causes of caseous necrosis, image of identification of caseous necrosis, which I always say a very hot topic. Based on leprosy, it was, I think, the dermat and pathology related question. It was a match the following kind question. Proto-oncogenes, and also in that, the option related to anti inflammatory cytokine, that was there. A question on primary immunodeficiency disorder was there, and a question on allograft rejection was there. These are something which are no integrated with your clinical subjects. It's not isolation pathology, right? So that's what you need to know here. Then, with respect to systemic pathology, we had many questions starting from aneurysms, Kawasaki disease. This was integrated with medicine, adenocarcinoma of lung, a image-based question, markers of neuroendocrine tumor, IHC marker of GIST, inflammatory bowel disease, the differences between ulcerative colitis and Crohn's disease, cholangiocarcinomas, drug-induced tubulointerstitial nephritis, Wilms tumor, which is integrated with surgery, prognostic factors of breast carcinoma, then medullary carcinoma of thyroid, which was again an image-based question, and rhabdomyosarcoma as from soft tissue tumors, right? From hematology and clinical pathology, we had a question on G6PD deficiency, Hodgkin versus non-Hodgkin, or true about Hodgkin. Then in clinical pathology, we had Sahali's hemoglobinometer, urinary crystals from urine cytology, and of course one question on fish. Okay. And then blood banking, we had total 5 questions. One is blood donation principles, blood components and their shelf life, the component which you want to give in hemophilia, transfusion transmitted infections, and lastly, transfusion reactions. So this is the entire picture of the topics. I think I answered Aniket's question. Ma'am, what were the questions based on? So on these topics, the questions were based on. Now, without much delay, let's look into the questions from general pathology. Okay, the first and very easiest, it's like a breather question. Differentiating apoptosis and necrosis, okay, is based on which of the all of the following parameters except is asked. Okay, so you use all these parameters to differentiate which one or which parameter is not used to differentiate apoptosis versus necrosis. So that is the question that you need to identify. We'll go to the option B, nuclear membrane. We always say that in necrosis, the karyorexis, karyolysis, all that is happening. So definitely you will talk about the nuclear membrane alterations here. So this is the correct one on which you can distinguish. Enzymatic digestion of the contents is going to happen in necrosis and not in apoptosis. Even that is correct. Intact cellular contents, intactness of cell. Where is the cellular content lost? Where the membrane, cell membrane is lost. So that happens in necrosis, and the opposite, it does not happen in case of apoptosis. So even this is correct. On which you cannot distinguish is based on the cell shape. We always talked on cell size. What happens in necrosis? The cell size is increased in size. What happens in apoptosis? Cell size is reduced in size. We never talk about shape, right? Whether it's crenated or what happens. We never talk about shape. So shape is the one thing on which you cannot differentiate between apoptosis and necrosis. Clear? So this is the correct answer. Now if we look into many more differences between apoptosis and necrosis, which is given in my notes in MedAce app. So you can see here that necrosis is always pathologic. Contents, they leak out. Cell size, we talk only about the cellular size, not about the shape of the size, this cell. Okay, this is very important. We are not talking about shape of the cell. Plasma membrane damage, nuclear changes in the form of pycnosis, karyolysis, karyorexis, all that is happening in necrosis but not in apoptosis, right? Other than this, what question you can anticipate in the upcoming exam is the marker of apoptosis. What is it? An exin 5. This is important. Okay, this is something you need to remember, and the pattern of the pattern that you get on electrophoresis. Okay, so on electrophoresis, what you get in necrosis is going to be a smear pattern, whereas in apoptosis what you get is ladder pattern because of internucleosomal cleavage, which is going to happen at regular intervals in case of apoptosis. Okay, so these are some more questions that you can expect in the next very upcoming exam, right? Moving on to the second question, I think that is apoptosis necrosis over. Moving on to one more question on the same concept, that is types of necrosis. So many of the students were telling me that this image was not really clear. It was very blurred, right? What I the students were telling was the pink amorphous material was there, which looked like caseous necrosis. And the history also said that there was a cervical lymph node biopsy which is given. Okay, so this is very, very important. Cervical lymph node biopsy is given. You are seeing amorphous necrotic eosinophilic material. See, you can see that a granular necrotic material, and all tiny things which you are seeing here are nothing but granulomas, and occasional giant cells can also be seen. But students were not really confident to tell that yes, there was a giant cell. Some were confused that they were naked granulomas. But what you should have seen is this caseous necrosis, which is characteristic of tuberculosis, and also there is history of the cervical lymph node enlargement. Sarcoidosis is more commonly in the perihilar area, and hilar lymph nodes are usually involved. And what you get is naked granulomas. Okay, this is important. Naked granulomas, which are characteristic of sarcoidosis and not of tuberculosis, and you don't see any caseous necrosis. No caseous necrosis in case of sarcoidosis, right? Hodgkin lymphoma, they would have shown you the nice Reed-Sternberg cell. For an undergraduate, that is how they diagnose Hodgkin lymphoma. Very rarely, yes, you can see granulomas. They are not caseating granulomas. LCH will show a lot of fibrosis and lots of eosinophils. Of course, these non-phagocytic histiocytes with grooved nuclei and other features will be present. You don't see this kind of caseous necrosis and granuloma in case of LCH, that is Langerhans cell histiocytosis. So the other features, if this is present, probably this is a foreign body type cell, giant cell. Here is a Langhans type of giant cell. This is again caseous necrosis. All these features would actually lead to the diagnosis, especially this caseous necrosis. This is very, very important. When you see this pink amorphous eosinophilic material and in the rim you identify some granulomas, and they're not naked, right? They're mostly the discrete ones and they have rimming by the lymphocytes. And here and there, you find this kind of Langhans type of giant cell. Definitely, this will not be the exact image, but based on your perspectives, like you said, pink amorphous eosinophilic material was there, and probably this is the one you're talking about, and this is nothing but caseous necrosis. Okay, where else do you see caseous necrosis? Anyway, this history said there is a lymph node involvement and biopsy is given to you. Of course, caseous necrosis can rarely be seen in syphilis, histoplasmosis, as well as in coccidioidomycosis. Okay, so there are other conditions. But see, sarcoidosis, no, there is no caseous necrosis. Hodgkin lymphoma, there is no caseous necrosis. There is no question of LCH that we have put here as differential diagnosis. I think the answer for this is clear, and it's very straightforward question without much difficulty. If you are good at picking up caseous necrosis, you are done with the answer, right? There was one match the following kind of question that the students vaguely remember. If anyone remembers, please put it here in the message. This was based on the different tests and the dermatologic infections. Of course, it was very, very easy. For leprosy, what you do, slit skin smear. For contact dermatitis, to rule out allergens, right? So you will do a patch test. For lupus vulgaris, to look at the morphology, you have to go for a biopsy. And tinea corporis, all those dermatophytes, how do you prove? By doing a KOH mount, right? But some students also said that there was another image-based leprosy question. I'm not sure what kind of question it was, but then what is important in leprosy is to differentiate lepromatous leprosy from tuberculoid leprosy. Okay, so here is tuberculoid and here it lepromatous leprosy. What is important here is to look at the epidermis, which is not thinned out. There is no Gren zone, a sharp, the separation between the epidermis and the dermis. So the subepidermal collagen that you see here in lepromatous leprosy. So this Gren's zone is characteristic of lepromatous leprosy. What is very typical here in tuberculoid is the serpentine granulomas. Okay, these are typically periadnexal as well as perivascular and perineural. Okay, big granulomas which are serpentine in nature is characteristic of tuberculoid, and sometimes you see even the giant cells like Langhans type of giant cells. What is seen in lepromatous leprosy is lots of foamy cells. You can see lots of clear spaces in between, right? So they are nothing but those histiocytes which are containing these lepra bacilli, right? So that is highlighted by what stain? What stain? That is modified Zeal-Nielsen stain, which is also called as Fight Farraco stain, right? This is important. Fight Farraco stain or Wade Fight stain. Okay, so that is for the lepra bacilli, and you describe the cells which contain these lepra bacilli as what? Verco cells or lepra cells. This is again important, and that cigar bundle appearance of those bacilli within the foaming histiocytes is referred to as globi. Okay, so these are some of the important parameters that you have to look in. Once this question on leprosy has come, you should be very much alert, because next time the question can be a image based, as some student already told that it was image based. Okay, but then actual I could not find any such question from other students, so I'm not discussing it in detail, but I'm telling you there are important differences between lepromatous and tuberculoid leprosy. Most importantly, the Gren zone, epidermal thinning, okay, and then globi of lepra bacilli. All those are very important features for lepromatous leprosy, where you have asymmetric, well-defined hypopigmented lesions for tuberculoid leprosy. The non-caseating granulomas, these are referred to as serpentine granulomas. Serpentine granulomas, which are very typical of tuberculoid leprosy, is what you need to remember, right? Of course, the bacillary load is more where in lepromatous leprosy and not in tuberculoid leprosy. It is very much less when compared to that of lepromatous leprosy. Moving on to the fourth question. This is again very straightforward. If you have would have referred to my lecture notes, any textbook actually it gives this. All of the following promote growth as proto-oncogenes except what? There are asking which of these the growth factors, they promote growth, that is as proto-oncogenes, except which option? FGF, fibroblast growth factor, it is in the name, right? And then PDGF, platelet derived growth factor. Yes, those two are definitely the proto-oncogenes. TGF alpha is also considered as a proto-oncogene. The moment you see TGF beta, you should be doubly alert, because you in the chapter on repair, as a role of M2 macrophages, what you have studied, it releases lots of TGF beta, and that is an anti-inflammatory cytokine. Very, very important. Anti-inflammatory cytokine. It leads to lots and lots of fibrosis, but definitely it does not, mediate a lot of cell growth, right? So this is the one option that you should have selected, and this will be the correct one. Okay, that is TGF beta, which is actually an anti-inflammatory cytokine and no role as a proto-oncogene. If you would have referred this, right? Uh, what are the important proto-oncogenes which act as growth factors and are implicated in different tumors? If I take PDGF beta, it is glioblastoma. If I talk of fibroblast growth factor, which was there in the option, right? Osteosarcoma and the bowel bladder cancer and breast carcinomas are associated with fibroblast growth factor. TGF alpha is associated with astrocytoma. Do we have any reference here on TGF beta? No, it does not act as a proto-oncogene. Of course, this time it is growth factor, next time it can be on the receptors. So please go through these receptors which are implicated in many of these cancers, okay, and they act as proto-oncogenes. And the moment you have got one option on anti-inflammatory cytokine, okay, so you should be again reading the other anti-inflammatory cytokines. So come on, are there any anti-inflammatory cytokines apart from TGF beta? It is interleukin 10, very, very important, right? So this is again given in my notes. So cytokines with anti-inflammatory actions, TGF beta, interleukin 10, other interleukins like interleukin 13, interleukin 4. We have some of the molecules like relaxins, resolvins and protectins. They also play a very important role in combating inflammation. So remember, this TGF beta derived from M2 macrophage doesn't have any role as proto-oncogene, is what you need to remember. Of course, there can be question on any of these interleukins as well as the tumor suppressor genes next time. So keep a watch on those topics, right? Moving on to the next question, which of the following is associated with repeated infections by catalase positive organism? So all the options here are from immunodeficiency. This is from the topic primary immunodeficiency disease. Some of the examples are from the defective innate immunity, and some of the examples are from defective adaptive immunity. If you look into these options carefully, you will know that which one is actually related to the innate immunity and which one is related to adaptive immunity. Only one option, that is CGD. Chronic granulomatous disease is the only option that is that is due to defect in your innate immunity, whereas the other three options, that is X-linked A gamma globulinemia, severe combined immunodeficiency and selective IgA deficiency, these are all actually from the defectiveness with respect to adaptive immunity, defect in adaptive immunity. Now, the bacterial infections are usually they are combated by what? First by the innate immunity and then by adaptive immunity, right? Now, catalase positive organisms, mainly meaning the staph aureus, and they require the phagocytosis, okay, and for which they take the help of NADPH oxidase mechanism, and that NADPH oxidase mechanism is defective where in chronic granulomatous disease, and that's why straight away this is the answer for this particular question. So we have repeated infections by catalase positive organism in CGD. What else is very important feature with respect to chronic granulomatous disease that you need to remember is nitro blue tetrazoleum test, okay, that's going to be negative NBT, you will not get the colored product engulfed by your WBCs in case of chronic granulomatous disease, because the phagocyte oxidase enzyme, NADPH oxidase enzyme, is defective in this particular disease. So next time there can be a question on all these options which have been given, right? That is X-linked SCID as well as selective IgA deficiency. So let's quickly go through the other options. First is CGD only, the answer per se, chronic granulomatous disease, which is due to deficiency of this NADPH oxidase, that can be either related to your cytoplasmic membrane, or it can be a cytoplasmic component. So we have, depending on that, 91, 47 and 67 phagocyte oxidase, right? So this is associated with recurrent infections with catalase positive organism. Though we said staphylococcus, you should be alert in those situations wherein you remember, yes, this is a catalase positive organism, right? And your inflammation will be rich, containing lots and rich in inflammation, but it will have a lot of macrophages, no granuloma formation, no much of neutrophils. And if you do NBT test, nitroblue tetrazolium test, definitely there won't be any colored reaction that you see within the neutrophils because of defective phagocyte oxidase activity. What happens in X-linked gamma globulinemia is the precursor B cells never mature to mature B cells. So definitely there are no much of antibodies which are produced. This is what you need to remember, and patients would suffer from those infections where you definitely need antibodies to fight against. These are again common in males. H. influenza, Streptococcus pneumoniae, again staph aureus are common. Apart from this, you can get variety of infections from enterovirus, Giardia lamblia, etc. Okay, this usually manifests within 6 months after birth, and this is because of deficiency of Bruton tyrosine kinase enzyme. And in severe combined immunodeficiency, you all are familiar. It is can be autosomal recessive or it is X-linked. And in X-linked, you have deficiency related to interleukin 7, which takes care of most of the T cell function in the beginning. And in autosomal recessive type, it is because of adenosine deaminase deficiency, and patient would manifest with hypoplastic thymus as well as lymph node. And these are the patients who present with. So next time there can be a question on this with oral thrush, candidiasis, and then features of graft versus host disease, which is typically seen in these patients. In selective IgA deficiency, because that was one of the options given here, just remember that there can be anaphylactic reactions following the transfusion of blood which contains the normal IgA, and also there can be increased incidence of allergic as well as autoimmune disease in these patients. Okay, so primary immunodeficiency disease, as I said before, is also one of the potential topics where the questions can be a little twisted, and though it is simple to answer, but questions can be sometimes tricky in nature. Okay, so please go through this. So next question is one such question where I think I haven't yet got the complete correct question from the students, and request all of you who are watching this live session to post what was that question exactly. Okay, but I got to know that a graph of something like that was given, wherein the graft survival percentage was compared to time after grafting, and then anti-CD8 antibodies, and this is with the control which was compared. Then the occurrence of anti-CD4 lymphocytes antibodies, and then anti-CD4 and anti-CD8, something was given. So this kind of graph was given, and there were some multiple options like CD4 cells has no role in rejection, CD8 has no role in has major role in graft survival, CD4 CD8 T cells both play important role in rejection, and CD8 cells play no role in rejection. So with this question I can only understand that definitely this particular topic is very very important, that is allograft rejection, the mechanism of rejection also, and how is it mediated by. And you know that there is antibody mediated rejection and cell mediated rejection, right? We have cell mediated, okay, and antibody mediated. Cell mediated is mediated both by CD4 as well as CD8 T lymphocytes. Okay, it's not that CD8 only has a role, CD4 only has a role. If this question is really correct and what is a correct statement about this graph or something like that, then I would say both CD4 and CD8 T lymphocytes play an important role in rejection. What rejection? Cellular rejection. Whereas humoral or antibody mediated rejection, antibodies play a very, very important role. Okay, so you know that there is something called as direct rejection and indirect rejection. The direct is mediated when the graft antigen presenting cells present antigen to host T cells, whereas indirect is by the host antigen presenting cells would present antigens to host cells, right? So you know that hyperacute is antibody mediated, whereas acute can be both cellular as well as humoral. Chronic is also cellular and humoral, and in both, that is the T lymphocytes of both CD4 helper T cells as well as CD8, they play a very, very important role in the rejection. Okay, if you have to select from one of them, so then it becomes CD4, which plays a greater role when compared to that of CD8. Okay. So patterns of morphology of allograft rejection in kidney is also what you can look at, and you see here that in acute cellular rejection, right? Acute cellular rejection, both CD4 as well as CD8 T lymphocytes play a very important role, whereas humoral is because of antibodies which are generated against the graft tissue. So this is what you need to understand, and this particular topic is also important. C4D is again a marker, right? It's a complement derived product, and it's a signature for antibody mediated rejection, both in acute antibody mediated rejection and chronic active antibody mediated rejection. Chronic active antibody mediated rejection, it acts as a signature. So please read this topic and try to find out what that question exactly was, so that I can have elaborate discussion on that, right? So that's about the general pathology questions. Now moving on to systemic pathology. Uh, First question is, excessive destruction of the connective tissue causing aneurysm is seen in which condition? So all of them were causes to some extent. You have studied about atherosclerosis as a cause of aneurysm, but do you think there is excessive destruction of connective tissue? No. Atherosclerosis, there is deposition of this cholesterol, right? And then there is formation of that plaque, excessive smooth muscle proliferation, all that is happening. Then there is acute plaque change later on. So atherosclerosis is nothing to do with destruction of this connective tissue. Then you have to choose between Marfan syndrome and Ehlers-Danlos syndrome. Where is this breakdown of connective tissue happening is because of the fibrillin defect that is seen in case of Marfan syndrome and not in Ehlers-Danlos syndrome. Scurvy we have studied in factors affecting wound healing, vitamin C deficiency, and it can also lead to bleeding because of vessel wall integrity is lost, but the small capillary wall integrity is lost. We have not actually studied as a cause of aneurysm per se about scurvy. Now if you look into this particular flowchart, you will understand Marfan syndrome, Lloyd's-Dietz syndrome, and Ehlers-Danlos syndrome are the important congenital causes of aneurysm. And now you have to decide between these two. That is, you have confusion between Ehlers-Danlos syndrome, okay, and then the Marfan syndrome. These two you need to pick up. Now, if you have studied and the acquired causes, of course atherosclerosis, yes, that's the cause, because of medial degeneration will happen. Hypertension, syphilis, transmural MI are the other causes. The question says the important cause here is excessive destruction of connective tissue. That is a primary cause for aneurysm. So what is that option, or what is that disease? So if the disease is associated with abnormal fibrillin 1, that is occurring because of the gene mutation, that is FBN1 or the fibrillin gene, that results in weakening of connective tissue framework, meaning the excessive dissolution of the collagen of the connective tissue is happening, and that is excessive activation of TGF beta is also happening, and there is loss of extracellular matrix mediated by TGF beta. All that is explained by which syndrome? That is Marfan syndrome. So the final answer for this question will be Marfan syndrome, where you have excessive destruction of connective tissue causing aneurysm, and you don't find such defect in case of Ehlers-Danlos. Of course, the variants are very, very different in Ehlers-Danlos, and of course the mechanism is also going to be different, right? So there can be next questions on Marfan syndrome. So just a fibrillin 2 defect results in what is known as the congenital contractural arachnodactyly. CVS will have mitral valve prolapse and aortic regurgitation. Of course, the ocular symptoms like ectopia lentis and retinal abnormalities can be seen in Marfan syndrome, and Ghent criteria is what is used in the clinical diagnosis. Clear? So this question was pretty simple. Now, one more point here before I go to the next question is the aneurysm which affects the abdominal aorta and thoracic aorta. So, if I ask you what is the common cause of aneurysm affecting the abdominal aorta, then the answer should be atherosclerosis. And if I ask you the thoracic aorta aneurysm, okay, thoracic aorta aneurysm cause, then what is the answer? Hypertension is the answer. If atherosclerosis, abdominal aorta aneurysms. This is for the acquired causes. Okay. Moving on to the next question. This is from vasculitis. Of course, there's a lot of overlap with medicine, not a feature of Kawasaki disease. You have studied Kawasaki disease, mucocutaneous lymph node syndrome, right? So, cervical lymphadenopathy is always there. Mucocutaneous. So, what will be there? Cutaneous rash will be there. So, polymorphic rash, that is also correct. So, cervical lymphadenopathy is there, polymorphic rash is there. Then mucosa is involved, right? Strawberry tongue, the strawberry appearance of strawberry for a cholesterosis of gallbladder. Then we have TB, trichomonas vaginalis infection, right? That is also strawberry vagina. Then we have strawberry tongue for Kawasaki disease. So you are sure about these three. Now comes the tricky option, that is purulent conjunctivitis. Yes, but conjunctivitis is present, but it is non-purulent conjunctivitis. And there is a popular mnemonic called face cream to remember this Kawasaki disease features, which I'll be dealing with. And you know that this is a medium sized vasculitis from the Chapel Hill classification, which is given here, right? PAN and Kawasaki disease are medium vessel vasculitis that can also affect the larger vessels. And you should remember that this is commonly seen in children. And one more question that can come on Kawasaki disease is anti endothelial antibodies. That's going to be, for your future. And then involvement of coronaries can cause MI even in the children, and fibrinoid necrosis is the hallmark lesion. But then the amount of fibrinoid necrosis seen in this condition is less than what you see in the polyarteritis nodosa. So this is the mnemonic. Face cream. Face, F for high fever, C for conjunctivitis. Very simple, non-purulent. If you are very much attentive to these options, you will be able to answer this. R for rash, E for edema, A for adenopathy of the cervical lymph node. Just remember adenopathy, that is lymph node enlargement, and M for mucosal involvement in the form of strawberry tongue. So mucocutaneous lymph node syndrome along with fever and non-purulent, very important, conjunctivitis for Kawasaki disease. Very straightforward. Next question, that is image based, right? Lung biopsy is given to you, and I'm sure this was not the exact image, but then yes, malignant gland is seen. So straight away the diagnosis should be adenocarcinoma, nothing other than that. Why not it is squamous cell carcinoma? There are no keratin pearls, right? And why not it is small cell carcinoma? You will see small cells, number one, lot of necrosis, mitosis, and azopardi effect. Azopardi effect, which is a feature of small cell, should be seen. And large cell, no more you are seeing large cell. And nice glandular pattern. Glandular pattern is very characteristic. Malignant gland formation, you have to go for adenocarcinoma. Straightforward diagnosis, nothing much to worry. And I will say it's the easiest question that was asked, right? So this I had shared long back, right? This is even given in my notes also. You can have a look of markers and what are the characteristic histopathologic features, where is it present, is it in the hilum, and what are the IHC markers. If you look at here in the small cell cancer, I have put the markers as synaptochromo INSM1, that is insulinum associated factor. This was asked in this particular exam. Very next question, probably the IHC marker, which is nuclear marker for neuroendocrine tumor, and here is the answer, INSM1. I did not mention it was nuclear or cytoplasmic, but this is the answer for that particular question, which is also positive in small cell cancer. Keratin pearl, if you see same lung tumor, next time it is a lot of squamous cells with keratin pearls, the answer should be squamous cell carcinoma. Okay, and any paraneoplastic syndromes associated with these, like SCC, it is hypercalcemia, gynecomastia, it is large cell carcinoma. Such questions can also be asked. Now, just to recapitulate, this is adenocarcinoma, this is squamous cell carcinoma, where you see a vague keratin pearl, and this is an example of small cell carcinoma. Small cells, lot of nuclear molding, and azopari effect, that is basophilic incrustation of the blood vessel, which is seen in this particular case, right? Moving on to the next question, as I already told you this, the nuclear marker of neuroendocrine tumor. Probably till date, I have not even taught my PG, right? Because we always talk about synaptophysin, chromogranin, NCAM, or CD56. But you would have tried this. I don't say that, yes, everybody should have done this for sure. No, this is not such a question. But then, you know that neurosecretory granules are present in the cytoplasm. So definitely this is not going to be nuclear, though they are markers of neuroendocrine tumor. Correct? NCAM, the option says cell adhesion molecule. Cell adhesion molecule. Cell adhesion molecule, are they present in the nucleus? Definitely not, right? They help in cell to cell adhesion. Probably they should be membranous. Even if it is not CD56, if it is NCAM, then it should have become more easy. That's membranous and it mediates cell adhesion. So even this is not there. So what is left out of, excluding the other option? This was the correct answer. That is INSM. This is the recent marker, insulinoma associated protein 1, which shows the nuclear expression. In some cases like colonic carcinomas, you can see nuclear positivity for CDX2 also, but then that was not there in the option, right? So INSM1, so this is what you need to remember, and that's the correct answer for this particular question. So salt, pepper, chromatin we have seen. The nested pattern of arrangement, sometimes in the question might say that there is organoid pattern or nested pattern, nested bar organoid pattern. So that again favors the diagnosis of this particular entity. So put other markers which were previously used like NSC and LU7, and these are not used nowadays. Remember, all these are the cytoplasmic and membranous markers, but this time what they asked you is the nuclear marker, that is INSM1. Moving on to the next, which of the following is not a marker for GIST? This GIST is a very, you should know the gist of GIST, otherwise you will be in trouble, right? CKIT is positive, meaning CD117 or CKIT is positive. You agree. PDGFRA mutations are seen in up to 8 to 10% of the cases of GIST. So this is also correct. This is also correct. SDH, succinate, I always say that SDH mutations is something that you need to remember. That is in pediatric GIST. You'll see in cases of pheochromocytomas, you will see in some cases of renal cell carcinomas, where these tumors are associated with succinate dehydrogenase mutations. So when you say all these are involved, so what is not involved? NRF is told by some students, and some students told it as NRG1. Whatever it is, this is a rare tumor marker, probably in some pancreatic cancer. So we will not go into the details of all this, but this is not associated with GIST is what you need to remember. Of course, there can be questions on IHC markers like DOG1, CD34, apart from CKIT in future, and of course the histopathologic types like the spindle cell type as well as epithelioid type of GIST, right? So pediatric GIST, which is associated with succinate dehydrogenase. Next is cholangiocarcinoma is seen in all except. Again, a very, very straightforward question. Any chronic infection of the liver causes both hepatic as well as this bile duct cancer. So naturally hepatitis B, C both are involved. Primary sclerosing cholangitis, yes, it actually is a important lesion or the risk factor for cholangiocarcinoma. Infection by Clonarchus and Opistharchus, both are correct. Now they have not given you Caroli syndrome, meaning there is bile duct malformation, but also there is congenital hepatic fibrosis, right? If it is Caroli syndrome, then there is naturally some risk for cholangiocarcinoma, but they have given you Caroli disease, and it is very, very straightforward, and this is not associated with cholangiocarcinoma. If you read this, so what are the risk factors for cholangiocarcinoma? PSC is there, fibropolycystic liver disease is there, means fibrosis also should be there, and cystic disease. Liver fluke infestations like Opistharchus and Clonarchus is there, hepatitis B, hep C, and non-alcoholic fatty liver disease. All those are risk factor for your cholangiocarcinoma. So this is a very straightforward question and nothing to worry about, and be in confusion. One more student actually had put this question in a different way. Only by one student I received such question. So clonarchia sinensis is associated with which of the following type of malignancy? I don't think so. This has actually come, but naturally it is associated with cholangiocarcinoma and not with any other options which are given to you, right? Moving on to the next question, what is true is in contrast to ulcerative colitis, Crohn's disease, meaning what is true for Crohn's disease and not for ulcerative colitis. Okay. Skip lesion, is it seen in Crohn's disease? Correct, right? Increased risk of colon carcinoma? No, we have more increased risk in ulcerative colitis. Seldom presence in daily hematochezia. That is also correct, right? It does not often presents with hematochezia and increased frequency of perianal fistula. All these are correct with respect to Crohn's disease. Fistula formation, stricture, fibrosis, perforation, serositis, all these things are true for Crohn's disease, not for ulcerative colitis. I think this should be a multiple options question where you have to select A, C, D to be true for Crohn's disease and not for ulcerative colitis. So these are the important difference. This one table that you have to see it again and again so that you'll be confidently differentiate between ulcerative colitis and Crohn's disease. And always remember, anti-Saccharomyces cerevisiae antibodies also help in, like they are present in Crohn's disease, and P-ANCA antibodies are present in ulcerative colitis. The risk of colonic adenocarcinoma is more in ulcerative colitis. Crohn's disease, when it involves colon, yes, there is not nil actually. When it involves colon, there is some risk of colonic adenocarcinoma in Crohn's disease too. Okay, this question again, it just said WBC casts were there, eosinophils were there, and drug history was given. History of fever, sore throat. So, moment you see history of fever and sore throat, and option is something related to kidney, please just don't jump to post-infectious glomerulonephritis. Be patient to read what is given. So, patient was on antibiotics, he developed pain abdomen, then peripheral smear showed eosinophilia maybe, then urine cytology revealed WBC cast. All those things are present, and what is the most likely diagnosis? So now there are different stories. WBC cast is there. They never gave you the picture of nephritic syndrome. Just forget this. Post-infectious glomerulonephritis. We are talking about cast, meaning some tubular disease, right? Are we talking about lupus nephritis? No, no. They never told about complements, low C3, C4, nothing like that, and no malar rash. So we should not think about lupus nephritis now. Pyelonephritis versus acute interstitial nephritis, because there is drug history and also eosinophils, right? These two are pointers towards acute interstitial nephritis. Pyelonephritis, of course, you would see only WBC cast, and probably you will not see all this eosinophils and drug history, though it may be seen, but most appropriate diagnosis in this particular clinical setting is acute interstitial nephritis or acute tubulointerstitial nephritis, and that's probably drug induced, and you have eosinophilia to explain all this, right? Next is about which of the following statements is false about Wilms tumor. So there were many questions like this, no, all except true about, false about, something like that, right? These are again, this is a straight question from your notes as well as many of your books. 85% good prognosis after chemotherapy. Yes, now you have a very good survival rate for these patients. Presence in childhood, all of you know by 3 years, yes, most of the kids present. Presence as abdominal mass, that is also correct, but this is wrong because many of the patients actually present with lung metastasis. That is quite common in case of Wilms tumor. Okay, so this was the correct one. Lung metastases are rare, is a wrong thing. That is not seen in case of Wilms tumor. That's a common thing and it's seen as clinical presentation, right? What else you have to see in Wilms tumor is the prognostic factors like anaplasia. The histologic features are the important prognostic pointers. The triphasic that this differentiation of the blastemal component, the epithelial component, the stromal component is what you have to see. And then three syndromes associated with Wilms tumor: Denish-Ras syndrome, Beckwith-Wiedemann syndrome, and Wager syndrome, and WT1 mutations which are associated. All these are important about Wilms tumor. Next is in breast. Okay, in a known case of carcinoma breast, why we use ER/PR? That was probably the question. If anyone knows this question, please complete this. So this is what I have got. Is it of diagnostic value, prognostic value, predictive value, or it's a surrogate molecular marker? It is definitely of prognostic. You have studied it in prognostic markers of breast carcinoma. Definitely not of diagnostic. Histopathology plays an important role in diagnosis, right? And then surrogate molecular marker, no, you have to do even other things like HER2 new PR, to establish the molecular diagnosis. The important powerful prognostic factors are again lymph node involvement and distant metastasis only. But then histologic type, this molecular subtyping, ER, HER2 new, there are also the other prognostic factors in breast carcinoma, right? So this is how you see the nuclear positivity for ER when you do this on a breast carcinoma slide. And again, I'm telling you, this is going to be a potentially important question, that is the molecular subtypes of breast cancer. Please go through that. You'll get to see that ER positivity, PR positivity, and low Ki is seen in luminal A, whereas high Ki in luminal B. We have something called as triple negative and HER2 only positive types. These are potentially very, very important questions for your upcoming exams. Next is a woman with hoarseness. So there is hoarseness, and a neck mass with there is a mass which compresses trachea. So naturally you'll think of neck mass. Something is problematic with the neck, and you have tumor cell nest. The moment you see this nests, okay, you have to organoid pattern, nest pattern. Think of neuroendocrine, and pink amorphous amyloid stroma is given. Maybe they have given you pink amorphous extracellular material. Then you have to think of amyloid. So you have amyloid material, you have cell nest. So they are talking about which tumor? Medullary carcinoma of thyroid. What is the cell of origin? Of course, it is from, is it from Hurdle cells? No, they are not from Hurdle cells. They are all actually follicular cells which have transformed. They're enlarged in size with abundant eosinophilic granular cytoplasm. We call them as oncocytes, Ashkenazi cells, or Hurdle cells. Both are same actually. Then follicular cells give rise to papillary and follicular carcinomas, anaplastic carcinomas, but not the medullary carcinoma. Medullary carcinoma arises from parafollicular calcitonin secreting cells, so that is parafollicular C cells. That's the correct option. There's no much of difficulty in this. Papillary and medullary are two things in thyroid tumors that you should be familiar and able to answer every question related to it. Then in soft tissue, again, favorite question. Cambium layer is seen in which of the following tumors? I have told you this in my class. Cambium layer is characteristically seen in botryoid rhabdomyosarcoma or sarcoma botryoids, which presents like in a hollow cavity, grape-like vesicles, which pop out, right, involving the vagina, urinary bladder, etc. Definitely, it's not seen in Wilps tumor. It's not seen in renal cell. You have a lot of clear cells or chromophobe, depending on the histologic subtype. In germ cell tumors, also you don't see this. So cambium layer is typical of sarcoma botryoids. So this is mentioned even in my notes, like sarcoma botryoids. It's a grossly masked lesion with a bunch of grapes. And cambium layer, what is this cambium layer? It's a condensed portion, okay, condensation of tumor cells just beneath. You have urothelium. Supposingly the tumor is in the urinary bladder. Just beneath the urothelium, you have lots of tumor cells which are present there. So this particular variant of rhabdomyosarcoma has better prognosis. Please read thoroughly this rhabdomyosarcoma, which is a very important and potential topic for your upcoming exams. So that's all about systemic pathology. Moving on to hematology and clinical pathology. The first question, again, very, very simple. We always talked about nutritional anemia, hemolytic anemia. This time it was from G6PD deficiency. So all are features of G6PD except Haynes bodies. Do you agree? Is it a feature? Yes. Why it happens? Because of oxidative stress. What is Haynes body? Denatured hemoglobin. Why is it denatured? There is no protection against the oxidative stress. Why there is no protection against oxidative stress? Because the NADPH is absent. So all are going hand in hand, correct? So they are all friends. Yes, 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 right. Now, what is not a feature of G6PD? Very, very obvious and an easy option. Equally affects males and females. Do you agree, students? No, this is a X-linked. So X-linked, definitely males are commonly affected when compared to that of females, and that's how D becomes the correct answer here. So always be familiar with this J6PD deficiency. There can be lot many questions which can be asked, and there is both combination of extravascular as well as intravascular hemolysis, and these Haynes bodies should be demonstrated by what? By using a supravital staining. Very, very important. You can't see on Leishman stain, regular staining and examination under light microscopy, and be familiar with this ABCDEF of your what? X-linked recessive. We always told autosomal dominant, autosomal recessive, X-linked dominant, recessive, by heart, like anything. Those mnemonics are given to you. You have to just go through by heart, and when they say male equal to female, immediately you should raise the eyes and easily select that correct option. X-linked males are commonly affected than that of females. Next question is, which of the following are correct statements about Hodgkin lymphoma? Again, a very popular and famous question. You should not take much time. Yes, this is B cell in origin. Yes, germinal center B cells. RS cells are positive for CD30, PAX5. Even if they give you for CD15, correct. Classical type is positive for that also. Most common type worldwide, what it is? Nodular sclerosis. If it is most common type in India, then it is mixed cellular. Does it involve mediastinum? Yes, it involves mediastinum. Does it involve Walde's ring? Is it the common site? No. NHL, non-Hodgkin lymphoma, usually involves such sites and not Hodgkin lymphoma. So it was again a pretty straightforward question where it asked you just to differentiate Hodgkin lymphoma from non-Hodgkin lymphoma. Hodgkin lymphoma, contiguous spread, cervical, inguinal, your axillary lymph nodes, all those are commonly involved. Whereas these rare sites are involved by NHL, where there is increased chance for spread through the bone marrow, and then you don't have type B symptoms that you typically see in Hodgkin lymphoma. Prognosis of HL is better when compared to that of NHL. These are the different subtypes. This table again you have to be really really familiar with to answer any question which comes related to this particular Hodgkin lymphoma. Now the parameters on which Hodgkin and non-Hodgkin I have already told you, so I'll not go into this. Chromosomal defects are again many in case of NHL in terms of deletion, amplification, translocation, whereas aneuploidy is the only defect that you see in case of Hodgkin lymphoma. This nodal involvement of Waldeer ring that came here in NHL is a typical of NHL and not commonly seen in Hodgkin lymphoma. So there was a question on hemoglobin estimation by colorimetric method, that is based on the color that it develops when we convert the given blood sample into acid hematin by using NMET and HCl. You take about 20 microliter of blood, and there were some set of instruments given to you, and I don't know whether it was all the instruments, it was like multiple options clicking type. So if there was a hemoglobin pipette, this is a hemoglobin pipette, right? And this is the hemoglobin tubes, Sahali's graduated hemoglobin tube, and then this is the colorimeter, okay, or color comparator, and this is the stirrer. So if all these instruments are given, then all those are components of colorimetric estimation of hemoglobin by Sahali's method. I think probably we asked the students repeatedly. There was no instrument like RBC pipette, WBC pipette. We had hemoglobin pipette. So this is hemoglobin pipette, and this is a Sahali's tube. This is a color comparator, and then we have stirrer. Okay. Then one more question again, is very straightforward. They said urinary crystal is there, coffin lid appearance is there. Straightforward. That is triple phosphate, or if the option was true white, even that is also okay. True white stones. Okay. So familiarity with this uric acid, which look like petals. Okay. This is one such example. Then we have calcium carbonate and calcium diphosphate. They don't look like this coffin lid appearance, and you can go through the notes which is given by me, and definitely we have explained all the crystals and which acidic pH, or whether they are present in alkaline pH. Triple phosphate, I've told you, it's in the alkaline urine, usually with Proteus infection, and has got coffin lid appearance. If you look into other like calcium phosphate, where we have fan shaped crystal, something like this, and then calcium oxalate looks like envelope. Okay, many a times students confuse this with this. Oxalate is envelope type, whereas triple phosphate is coffin lid type. Fish can detect all. This is a repeat, whereas that time it was PCR, now it is fish. Fish, yes. HER2 new amplification, don't you use fish? Yes, we use fish. So deletion, yes. Any gross structural changes, if you want to see big ones, then you have to go for fish. It very minute, like point mutation. How will you detect by fish? No, you have to first amplify it, and then you have to do it. So how do you amplify it? You do sequencing studies, or you do something like polymerase chain reactions. Okay, so the correct answer for this is point mutation. Next is a few questions on blood banking. Last four questions I have. 23-year-old male needs urgent transfusion. Blood group was announced. So it's a very simple one. Universal donor concept. So what would you prefer? You want to give blood, okay, not plasma. So they're asking blood group is unknown and urgent blood is needed, right? So I think this was again a multiple options question, and C and D were given. If this is given, both the sorry, it is O positive as well as O negative. So both O positive and O negative will be the correct options for this. If it is plasma, naturally would prefer AB. Why AB? Because the this will have anti A and anti B will not be present, right, in a patients with AB blood group if it is plasma. But you are giving what? Blood. So naturally, either you give O positive or O negative. O negative, O positive is preferred over O negative because only in exclusive like females and pregnant or other risk factors, yes, you have to give O negative. But if when in multiple choice, both can be given. So O plus and O positive as well as O negative becomes the correct answer. Match the following, very straightforward. Single donor platelet stored at room temperature. Half life, I mean, the shelf life is 5 days. Packed red cells with additive. When you add segum, it is 42 days. When you don't add, it becomes -7. So it becomes somewhere around 35 days. Okay. Granulocyte concentrate, not more than 1 day, meaning 24 hours. Fresh frozen plasma, or it is cryoprecipitate. Okay. Anything, you can keep it under frozen conditions for about 1 year. This was very straightforward and purely knowledge based question, and nothing to much to explain there. Which of the following infections spread by all components of blood? This was again a tricky question. You know that all these are transfusion transmitted infection. The question says all components of blood. Any component when you give, there is risk of transmitting this particular infection. Toxoplasmosis, this infection spreads mainly through the granulocyte concentrate. So we don't we can easily exclude. Filaria is also very rare infection to be transmitted actually through this blood transfusion. You have to choose between malaria and syphilis. After extensive reference, I've got in some of the literature, like malarial parasite can be transmitted through all blood components. This text is given, so I believe this is the correct option. Whereas for syphilis, it is given that it can be transmitted through fresh blood and platelet concentrate, and most of it gets inactivated between 2 to 6 degrees centigrade when the blood is stored, and there is no much risk of transmitting the disease. So finally, I come to the conclusion, for this, malaria is the correct answer and not syphilis. Which of the following is a treatment of choice for hemophilia B? Straightforward, but you should know what is used. Again, multiple correct options you need to pick up. Factor 8 concentrate. Where do you give for hemophilia A, not for hemophilia B, right? Right? So this is for hemophilia A. Now you have to choose between FFP and cryoprecipitate. You know that FFP has all coagulation factors, whereas cryo is rich in factor 8, von Willebrand factor, and fibrinogen. So naturally you will use cryo again for hemophilia A. Now you have to choose fresh frozen plasma and cryopore plasma. If you have to choose the single best answer, definitely this is the single best answer. Then if there is a combination, next option you have to choose, then you can go for cryopore plasma. Ideally, this is used in the treatment of thrombotic thrombocytopenic purpura, but then this also is rich in other coagulation factor when compared to factor 8 and von Willebrand factor. So if you have to choose both, then DNC. Best option is definitely going to be D, that is only fresh frozen plasma. What is best? The best for hemophilia B, it is factor 9 concentrate only, right? So this is the correct option here. Next, there was a question that students were not able to remember clearly, that is delayed febrile. Later on inquiring, I actually found that it is delayed hemolytic transfusion reaction. So, which of the following is not a feature of delayed hemolytic transfusion reaction? In the question, they said delayed. This is the key word here. And in the option, they said cola colored urine after 2 hours. So, definitely there only is the correct answer. So, this is not. Whereas increased LDH, yes. Unconjugated bilirubin is increased, yes. Uncorrected hemoglobin, meaning the patient goes on showing the signs of anemia and hemoglobin is not corrected so easily. And this happens after 24 hours. It can go for months. There is fever, there is jaundice, then retic count is increased, spirocytosis can be present, and direct antiglobulin test is positive. LDH is also increased. LDH is increased in this particular condition. So definitely cola colored urine after 2 hours is the correct answer. Parvovirus B19 is associated with all except, what is the correct answer here? If you look into the things, only this one, right? Pure red cell aplasia, yes, is a feature. Transient aplastic crisis, you have read in sickle cell anemia, you have read in hereditary spherocytosis. Definitely this is correct. Hydrops vitalis, which is of non-immune type, is also seen in this condition. Whereas fever with petechial rash is a very, very rare manifestation of parvovirus B19 infection. Only patient present with erythematous rash in the form of slapped cheek. So that's how this is not the correct option. Okay, fever with petechial rash. There was one question on calcium related image based question. which probably I think if any one of you get the question what it is, whether it was stained with von Cosa, whether there was bluish chunky material like samoma bodies, please get back to me because I am unable to get this particular question. So 28 questions plus 2 questions. There were totally 30 questions which were asked in pathology. Quite a good number. Isolated, there were around 16, and again, we had along with other subjects, there were some other questions amounting to 14, and totally we have 30 with quite a good number of image based questions. So, I always tell you, as is your pathology, so is your practice, as told by Osler, but you should also remember that as is your pathology, so is your performance and practice with clinical medicine. That's the importance of pathology. No worries, those who have not done well, and those who have not those who have done well, keep this positive spirit and move on. All the best for your upcoming NEET. I want it to be very neat path for you. Thank you for your attention. Please contribute the questions which I could not, discuss here because of incomplete questions that were got from the students. Thank you, Manipal MedAce, for this wonderful opportunity. Signing off.